more important than the substance about what's happening in Washington these days. But again, I think the question is, it's a crazy time. What do we all do? And what I also start with or try to remind everybody is that none of us know what the right thing is to do, right? So we're also have to be forgiving of everybody. You know, whether we're talking to our federal partners, I don't believe that any of the career people in the federal government suddenly have switched sides and aren't our friends, right? So they're trying to protect us too, but maybe they won't know the right thing to do. I say that with advocates, right? But it's a confusing time. We're all in some ways gonna muddle through. So I'm not gonna read this. This is a vision statement of the National HIV/AIDS Strategy. But again, I put that up there just to remind you, okay, there's so much going on. What are we doing? And we're trying to create this as a reality, right? So let's just remember that. There's a lot we can't control, but this is the world we're trying to create, where HIV infections are rare and we really take care of everybody with HIV. So now I want to talk about a talk I gave at the US Conference on AIDS. You may know this is the largest annual domestic HIV conference, largely for community-based organizations. It was in September in Washington for 2,500, 3,000 people. And I gave the plenary this year. And because Gilead sponsored the plenary, I don't know if you've been to these events, it's like highly produced, there's lots of resources. So the talk I normally give, there was like much embellishments. And the embellishment was, there's this visual story behind it, but I framed my talk around having been a Peace Corps volunteer. I have this story like many returned Peace Corps volunteers. It was almost 30 years ago, but it shaped my life. I was a high school science teacher in Swaziland. And so I said that, and I said I'm now part Swazi. And what I told people, and it surprises me to realize how true it is. It was almost 30 years ago, but I have a WhatsApp group with my former students. We talk every single day. And I don't mean most days. I mean, I wake up with the time difference, and there could be 60 messages from all of them chattering about things. And it's like, part of the reason I'm telling you about that is this is one of the great things about our country. We send people around the world to spread peace, and we help underdeveloped countries, right? And so sometimes I'm telling you that because people, these crazy times, want to have reasons. How can we feel good about this place, right? That's one of the things we do right. So the next thing with my talk is to say, you know, you may or may not know, or I guess the same applies here, that Swaziland has the dubious distinction of the world's worst HIV epidemic. But in addition to sending people around the world through the Peace Corps, we have also committed to saving the lives of people living with HIV all over the world through the Peace Corps. I mean, through the PEPFAR program and the Global Fund. And I went to Paris, the International AIDS Conference, and I was at a reception with Ambassador Birx, who runs the Global AIDS program. You know how you have these conversations? She's a friend of mine. We're having a great conversation. But she told me something, and all I could do is like, I got to get out of here. I mean, she's talking about the progress we're making. The number of new HIV infections among adults in Swaziland has nearly been cut in half. The number of people on treatment is way up. Viral suppression rates have doubled since 2011. So I'm talking to her, and I'm just like, I got to get out of here, because I had to text my former students and tell them the news. And I'm walking down the streets of Paris. It's weird. I have this visual memory of where I was. I was crying, and I was crying not because it's great news that what they've accomplished in Swaziland, but it's also great news because they didn't do it alone. They did this with the United States of America. So again, at a time that other people are trying to redefine what makes us great or special, a country that does that, that commits to saving the lives of 12.3 million people living with HIV outside our borders, that's the country we've got to fight for. So I say that to remind you. Now, the purpose of the slide is then I go on and say, I'm not talking about Swaziland because of HIV. I'm talking to you about Swaziland because of how Swazi families respond in times of trouble. And I won't go into all the details, but what this is, my Swazi name is Mefiga Masego. And these are my sisters and brothers, but behind them is what's called a gogo hut. The center of every Swazi homestead is the gogo hut. Gogo means grandmother. And the gogo hut is where Swazi families gather in times of trouble. There's a place at the back. They'll brew some African beer. They place a clay pot of beer for the ancestors. But essentially, they'll commune as a family, talk to their ancestors, and figure out how to face their troubles. So I gave this talk and said, okay, this is what we do. I tried to acknowledge the trauma that we have all faced, right? But also acknowledge that we have a great family. There's so many parts of our community. Our family as an HIV community is strong. And so then the talk is, and this is the 4 points that I guess have evolved since the election. There's 4 things I think we do now. And what I said to them, I also want you to hear me as saying to you, and I'm not being glib, I mean this sincerely. I want to tell you that I love you. And I say that to mean that what we do now is we love each other. And I can make a joke about this like I did then, like, I don't know what the cattle ranchers do at their annual convention, but I don't think they're united by love. But think about how lucky we are. You know, I talk about Silicon Valley. They're in the business of developing a killer app to make them billionaires. But what do? We go to work every day because we love our communities. We're in the business of saving and improving lives. So I want you to remember that, because how we survive this time is we love each other, right? So the next thing I talk about is that, you know, this conference was not right after, but following Charlottesville and other things. And there's a lot going on in this country. And I say that the second thing we do is we fight white supremacy, racism. You know, we defend our dreamers. We do all these things. And the way I think of it is we support all parts of our community. It's just weird. Some of you have been around a while like me. I remember a time when you'd go up to the Congress and they hated us. Do you remember what some of the things Senator Helms would say about people with HIV? Back at that time, though, politics stopped at the water's edge and we could do other things on a bipartisan basis, certainly our foreign policy. Now it's just this weird world we're in where we can't do anything on a bipartisan basis, but at least when it comes to HIV, it's become less partisan, right? So it's strange to me that we're not under attack because of HIV, but we're under attack because of who our community is, right? Whether we're immigrants, you know, I don't want to go through the list, right? But I also talk about how, you know, after the election, because of who our community thinks it is, we're activists. I was worried. I was afraid that we, above everybody else, would be in the streets in our anger in a way that would be harmful. We have vulnerable people in our community, right? And I was worried that we'd put a bullseye on our forehead. But that didn't happen. So what I talk about is I cannot tell you how proud I am with how our community responded to defend the Affordable Care Act. The DC-based groups, everybody mobilized. It was impressive. But it was really the marriage with our activists that did that as well. So you may have remembered this. There were some protests with the disability rights group ADAPT. And I know those people. I work in disability too. Some of those are my friends. But when they did this, I was like, oh, I felt a little sad. Like, where are our people? And then like 3 days later, they were there. You know, I think that's one of the things we do great, is we recognize that we all don't have the same role, but we all have a role to play. And the way we did this, it was just amazing. And I think that's the only way we've succeeded so far. So the third thing I think we need to do is to acknowledge the progress we're making, which is significant and real. I could run through the stats. We've heard someone say, I don't need to do that. But you know, we've been in some ways a steady state for HIV a long time, and things have started to change. We've got to keep that going. But at a time when we can acknowledge how many problems we have, even with the work we have to do, we have a lot of work to do, but don't feel hopeless. We need you all to remember the progress we are making. And then the fourth thing I talk about is what do we do in these crazy times? And it's really the purpose of this meeting, is we stay focused on what brings us together, ending the epidemic, right? Every day there's 10 things that could distract us and make us go crazy, right? Every day, like I don't know what's happened in the news today, but we have a job to do. You know, I made a joke about young people get sick of hearing us old folks talking about how it used to be, but think about that. Many of us did go to too many funerals in the past. We remember a dark time. If we could get through those times, we can get through this, right? And so those are, I think, the key things. I'm going to get to now the politics of DC, but if I say, what do we do in these crazy times? We love each other. We support all parts of our community. We acknowledge the progress we're making, and we stay focused, right? So that's what I want. Thank you. So now I'm going to talk about some things going on in Washington. I want to talk about some proposed structural changes, and those are three things. The efforts to repeal the Affordable Care Act, the efforts to gut the Medicaid program, and the forthcoming fight over tax reform and really tax cuts. So I chose this image intentionally. When we talk about structural change, what kind of change is this, right? Does it look very positive to you? I'd say all the proposed structural changes that are on the table seem to be negative. So health system reform. What's happened? And again, I could have given you 10 slides or 20 slides on this. I'm going to give you one. But even here, I don't want to, let's not get stuck on the weeds. But what happened? Congress failed to enact repeal of the Affordable Care Act after many attempts. At the end of September, their special authority to pass this with only a 50-vote majority in the Senate expired. So at least for the short term, efforts to repeal the Affordable Care Act are off the table. The administration already, though, has taken a number of steps to undermine the Affordable Care Act. Marketplaces, including a 90% cut in grants to support outreach and enrollment. They shortened the open enrollment period. And as you know, just last week, I guess, or maybe it was even 2 weeks ago, they announced that they weren't going to pay health plans for their mandatory cost-sharing reduction payments. All of these things are create great stress on the system and can only do harm. None of them will be individually catastrophic, but over time they're doing damage. What could still happen? They'll still find ways to sabotage this law that, again, while not individually catastrophic, will continue to have impacts where we'll drive up premiums. Maybe in some places plans will depart and federal costs will increase. And what I'm also worried about increasing discriminatory behavior. You know, a place we were in implementation, there are provisions in the Affordable Care Act that said you can't be discriminatory. And now we're at the phase where lawyers should jump in and should test what does that mean when you're discriminatory against plan design for people with HIV, for trans people, all these things. Now they're talking about repealing some of those things. But even if they don't repeal provisions, the intent to enforce the law has gone away. Medicaid reform. So again, their failed effort to repeal the Affordable Care Act, had they been successful, they would have eliminated the Medicaid expansion. You know, this is a part of the Affordable Care Act that covered all people at any income, or up to an income of 138% of poverty, but without regard to categories. Lost in the dust up, though, is that they would have fundamentally restructured the Medicaid program in a way that would have gutted it and made it less effective for the future. And they talk about shifting to per capita allotments. Again, I don't want to bore you with all this, but what it would mean, it's not an idea to make the health system work better, to make Medicaid better in any way. It's just a way to say healthcare costs go up faster than other measures of inflation, and the Feds is just going to limit its exposure right before we're faced with all the baby boomers, you know, retiring as we have stress on our long-term care system, and it's going to give us less flexibility. What are ways that we've used Medicaid to flexibly respond to unforeseen events? Well, the AIDS crisis came along. Well, 9/11 came along. Katrina and Rena happened. All of these are cases where, because there's nothing else, the Medicaid program is what was there to step up and help our country through these problems. And all the changes they would make would weaken our ability to respond to these future threats. So what could still happen? HHS has broad authority to waive requirements of Medicaid. They want to do things often like impose work requirements, which, again, are nonsensical when you look at the population, drug testing and other punitive measures. But in addition to state flexibility, they also just don't seem that focused on enforcing the law, which is a problem. The third thing, and this might be the thing that you've probably heard about, but I don't know if you necessarily fully appreciate how this is directly tied to their agenda on weakening our health system. So the House and Senate each passed what are called budget resolutions, which don't really have the force of law, but they guide their budget process for enacting a budget for next year. They did this what are called reconciliation instructions, but that's just a term for this idea that now under special rules, the Senate can pass tax reform legislation and only need a majority. They won't need a supermajority like other legislation does. It doesn't look like they're planning to use this to, again, try to repeal the Affordable Care Act or gut Medicaid, but there's nothing stopping them from doing it if they had 50 votes to do this. This party that forever was about, we've got to reduce deficits, a national crisis, we've got to reduce deficits. Now they want, their budget resolution says we can increase the deficit by $1.5 trillion over the next decade. And really the important point here is this is the first step of this two-step process to go back and say, because we have this exploding deficit, now we need to cut all these programs we care about. But even with these reconciliation instructions, this idea that even with this special procedure, it's going to be really tough for them to pass. And we've seen that play out. So they talked about taking away the deduction for state and local income taxes. That was off the table. Now it's back on. Just a couple days ago, the president said, no, we're not going to touch 401ks. They'll still get their tax-deferred treatment. Now today, we're reading that members of the House and Senate are saying, not so fast. We're not sure we care about what he says. We might have to do this anyway. This just shows the jockeying because what they're trying to do still is difficult. So we'll see what happens. So again, this is just a slide from the Center on Budget that shows that cutting taxes is the first step. 80% of the tax cuts would go to the top 1% of income earners, and it would be used to justify cuts to Medicaid, Medicare, food assistance, Social Security, disability insurance, and other programs. So now I want to quickly run through the impact on the federal budget. And here, And on the one hand, it's not cheery, but it's also not horrible, right? So the president came in, proposed a budget that proposed huge cuts. Doesn't look like most of them are going to be enacted. So I'm going to explain this chart, but for every subsequent slide, I'm not going to do it. On the left is the budget for the current year, and below the number is the change from the year before. The next is what the president proposed. The next is what the HIV community asked for, and then what we're doing with the House and Senate, where they are in their process. And what I'd say is the president's budget for NIH proposed to cut NIH's budget by $7.2 billion, but the House voted to increase their budget by $1.1 billion, and the Senate voted to increase it by $2 billion. So if the House and Senate then get to a negotiation, we're talking about an increase, right? We don't know what's going to happen with the AIDS research budget. But again, my take is that at least some of the pressure's off because we're talking about increases, right? So if they had enacted draconian cuts to the NIH budget, I think our budget would be under more threat. I just want to quickly talk through just some of these other programs. HRSA's budget, looks like we're getting a flat funding. It's a relatively good outcome. The president, before he put out his budget, made some comments about programs he liked and didn't like. He said very positive things about the Ryan White program. Then he proposed to cut it by $58 million. Anyway, I think, again, we could talk about why it's good or bad, but that's a relatively good outcome. CDC, the Trump administration proposed huge cuts to HIV prevention, $148 million. Modest cut, well, a negligible cut to viral hepatitis, a significant cut, $22.3 million to STD prevention. But it looks like we're really talking about flat funding here across the board. I think that's pretty good. But I just point out, especially when it gets to viral hepatitis, as a nation, we spend $35 million to respond to viral hepatitis. It's just negligible. And so we need to be talking about doubling it year after year and just to start to get to scale. But we do need to just watch what's going on here to protect our funding in these other programs. SAMHSA, the reason I put SAMHSA up here, the administration proposed to increase by $127 million. The House proposed to cut by $300 million, and then the Senate imposed an increase of $13 million. So they're just all over the board. Some of this has to do with that they want to respond to the opioid crisis, and maybe they would do it in different ways, but it's just hard to figure out. And then lastly, HOPWA, they got a relatively significant increase last year, $21 million. And just the backstory on that is we finally enacted through legislation an update to the HOPWA funding formula. So it's not based on just cumulative AIDS cases, it's living HIV/AIDS cases. To make this work, they really needed to bump up at funding. But now, again, the president's budget proposed to take that away. The House proposed an increase of $19 million. The Senate, a decrease of $26 million. So that's really in flux. Hopefully we'll come out at least flat funding, but who knows. So now to wrap up, I just have 2 more slides, and I'll stay in time. You know, this is a time of uncertainty, but I like to remind people, okay, we work in HIV. When was that magical time in our past when things were great? When was it a time that they saw us come and said, oh, the HIV community, let's hug you, right? Things are horrible for lots of people in this country. We know that. I'm not making light of that. But when was our discourse normally truly respectful of women, of immigrants, right, and people of color? And again, I'm not making light of that, but what I'm saying is we're tough people. We've been through this before. We've got to remember how tough we are. And we have more allies than we've ever had before. HIV has become more bipartisan. So what do we do to end the HIV epidemic? We love each other, but what I mean by that is you all individually have to protect your own resiliency, because we've got to take care of ourselves first, because we have a community to take care of. Second, we've got to support all parts of our community, because in face of a hostile environment, we need to do more to show our community how much we care about them, right? So that means being more outspoken about these other threats. We don't just care about the HIV part of people's lives. We do need to recognize the progress we're making. I think we need to make sure we're telling the compelling story of our success, because people want to buy into success. So whether it's policymakers in Washington, elsewhere, want them to say, hey, they're doing some things right. I want to be part of that. And that's our job. And then lastly, I just say we need to stay focused on ending the HIV epidemic. And there is a lot going on. These are terrible times in a lot of ways, but none of that absolves us of the responsibility to end the HIV epidemic. Thank you so much for the work you guys do every day.
Thank you, Jeff. I couldn't help when you you're talking about all the I love you sort of stuff, I couldn't help but think of our current president saying that. Really is kind of a positively creepy image. Okay, so I'm going to now turn it over to Laura Thomas, who is currently the Deputy State Director for California at the Drug Policy Alliance. You will note if you read her bio, though, that she got her start in ACT UP, which is always sort of cool. And I will just say, I have a friend who always tells me I'm a knower of things. Laura Thomas is even more of a knower of things. I always learn something from you. So I'm going to turn it over and learn more now.
Excellent. Thank you, Wayne. Yeah, I've got a set of things that people ask me about, including birds. So my coworkers will send me blurry photos of hawks from a distance and say, what kind of a bird is this? So you're welcome to join them if you have blurry photos of hawks that you need identifying. I will do my best. But yes, I'm Laura Thomas. I'm currently the interim state director for the Drug Policy Alliance here in California. And I'm really excited to be here and get to talk about some of my favorite topics. So supervised consumption services, drug policy reform, harm reduction, and the connection between all of that and how we get to zero in HIV. So I'm going to talk a bit specifically about the intervention of supervised consumption services, and then more generally about the sort of broader context of drug policy reform and what we're up against. As Wayne said, I got my start in ACT UP back in the day, and a lot of what Jeff was saying really resonated with me of, you know, I've been through this time where I was going to a funeral every weekend where my friends were dying all the time, and you know, my friends and I have this debate, are things worse now or were things worse then? And I get kind of frustrated with that. Things were bad then, things are bad now. They're just bad in different ways. And hopefully we've learned some skills and resiliency to deal with it a little bit better. With that, how am I doing this? There we go. So in terms of talking about HIV and people who use drugs, these are pretty obvious statements, I think, that I'm sure everyone here already knows. So sharing injection equipment remains one of the major routes of transmission for HIV in the US. Other drug use, in addition to injection drug use, such as alcohol, can also lead people to engage in risky behaviors and make them vulnerable to HIV. The opioid overdose crisis is a leading cause of death for people with HIV, and it's certainly a leading cause of death beyond that as well. It's the leading cause of death for people under 50 in this country. Overdose is the leading cause of death for people under 50 in this country, and we have about 1 overdose death every 9 minutes, which for those of you who share my ACT UP past, we used to have chants about 1 AIDS death every 15 minutes and things like that, and overdose has outstripped even the worst years of the HIV epidemic. And then criminalization of people who use drugs creates more problems and barriers to care and disrupts their ability to access services. So that's sort of the background why I'm starting with this. So what are supervised consumption services, also called supervised injection facilities, drug consumption rooms, safe injection facilities? These are all various names for describing a place where people who use drugs can go, can use them safely under some form of sort of often medical, peer, otherwise trained supervision, with the ability to intervene in case of an overdose or some other adverse health effect. And it is safe, it's non-judgmental, and it's legal. And the history of these programs goes back decades. The first ones opened in Switzerland in the mid-1980s. They are now well over 110 countries. Currently, Canada is the only North American country on that list, where Insight in Vancouver, British Columbia opened in September 2003, but the growth of these programs has exploded over the last year in Canada, and there are now at least 16. There are no authorized programs in the United States. There's one underground one that has been evaluated and researched and described. This is just a photo from Insight. One of the great things about Insight is because, partly because it was fairly controversial when it was opened, it has been heavily researched. And as someone who is a consumer of research, it's been truly a blessing to have all of the data from Insight. Because what it's shown, and I'll go through these pretty quickly. You're all researchers, and some of you are probably already familiar with this, but Insight resulted in reductions in public drug use, in reductions in syringe litter. It was associated with the increased attendance at detox programs, substance use disorder treatment, and in fact with ceasing to use drugs altogether. People who went to Insight were more likely to stop using drugs altogether than people who used drugs who didn't go to Insight. They've had many overdoses, but they have never had a single death at that facility. This is a photo of the inside. These are the booths where people come in and inject their drugs. And then specifically looking at the HIV and the Hep C impact, it's been extremely effective at attracting exactly the kind of high-risk population, people who are often referred to as hard to reach or hard to find. They walk right in the doors here. And they've been associated with reductions in HIV and hepatitis C risk behavior, both while they're there, and that protection extends even when they're not injecting there, but injecting elsewhere. They continue to use safer practices. It has not resulted in increased drug use, hasn't prompted anyone to start injecting, and hasn't led to any increases in drug-related crime. So these are just some quick charts showing the impact in Vancouver. These are issues that are very relevant here in San Francisco, and I get to talk about them a lot. But as the use of Insight went up, public injection drug use dropped off really dramatically, and the public disposal of syringes and other injection litter decreased. Those of you who are not from San Francisco, if you're staying at the hotel on Market Street, you may have noticed syringes on the streets. You're standing right in the middle of a lot of it. So that's one of the things that we're trying to address here. I take it some people saw some syringes, if not some public injection drug use behavior here. So people who inject drugs are much less likely to share syringes. And additionally, the cost effectiveness studies that have been done have focused or have gotten a lot of the cost savings from averted cases of HIV. Averted cases of HIV and averted cases of a Hep C both are really significant driver of the cost savings for these programs. So bringing us to San Francisco, here in San Francisco, this is one of the syringe disposal boxes that the health department has put up in a number of places around the city. When we look at what's happening in terms of the epidemiology, these numbers are all from the recent 2016 report that was just published. People who inject drugs are 21% of people living with HIV here in San Francisco, right? So 1 out of 5. We think of San Francisco as being, the sort of center of gay and bisexual men and HIV, MSM. And I want to say that this 21% includes people who are MSM IDU in terms of the category, so men who have sex with men and also inject drugs. Overdose is the third leading cause of death for people with HIV. After HIV-specific causes and non-HIV cancers, it's the third leading cause of death. People who inject drugs have worse outcomes, lower rates of viral suppression, et cetera. And while incidence, and I'm extremely proud that San Francisco has made such a huge impact on HIV incidence in San Francisco, we've dropped incidence for men who have sex with men, and we've barely budged the number for people who inject drugs. It is low, but it hasn't changed. So this is where I come up with the question of how do we get to zero without addressing this, and what does getting to zero look like if we're talking about people who use drugs? This is, and my obvious answer here is that supervised consumption services have something to do with it, and we're not going to be able to actually get to zero with this population without operating supervised consumption services. And when the data was, when researchers looked at the data around the cost benefit here in San Francisco, they felt like if we created something similar to Insight, replicated Insight, and plopped it down here in San Francisco, we'd be averting over 3 HIV cases per year, or 6% of the IDU-related HIV cases, which seems like a fairly small number. I think that's a very conservative estimate, and I think that that would probably go higher. But one of the things they also said was that this would be a natural center for locating people who inject drugs, providing them with testing, connecting them with treatment, and certainly that's partly true for substance use disorder treatment, but it's also true for HIV treatment and Hep C treatment. So this morning, because today has been a very good day, this morning, this San Francisco Safe Injection Services Task Force presented our findings to the San Francisco Board of Supervisors, where it was, this was a task force that was created by the Board of Supervisors to look at this issue and say, what should we do here in San Francisco? The task force strongly recommended that we need to move forward in opening multiple sites around the city. And this morning, the Director of Public Health committed, she said within 8 to 12 months, she would have these sites up and running. So we're moving, yes. And I have to say, this has been like a 10-year battle working on this. So today was a very exciting day, but I'm hopeful that we're going to be able to do this, and we're going to be able to put, among other things, put a dent in our HIV numbers for people who inject drugs here. And let's zip through some of this. So we're in the process of trying to pass legislation to make this happen here in the state. We made it all the way through the Assembly and most of the way through the Senate this year. We came 2 votes short, so it'll come back in January when the legislature reconvenes. And there's similar legislation in other places around the country. We're trying to take some lessons from syringe access. But I get asked this a lot, or in terms of getting to zero. Why isn't syringe access enough? And some of these are Hep C issues, because I think if we're only focused on HIV and not on Hep C, we're missing a lot. But Hep C is more transmissible, and so it's not enough to just have a sterile syringe if you're sharing any of your other works, cookers or cottons. And the accidental SIF, the accidental supervised injection facility, there was actually a great piece on CNN last night with Sanjay Gupta talking about bathrooms in programs. And any of you who work in any community-based organizations, you may be familiar with where people inject drugs in the bathrooms. And it can be a problem for a whole bunch of different reasons, not the least of which is the safety of the individual who's injecting drugs in the bathroom, who may overdose and not be found until it's too late. So we know that this is happening in a lot of programs and clinics around the country, and it's including in the bathrooms of needle exchange programs, which sort of proves the extent to which we need these programs. And then just sort of talking about criminalization, because this is also part of my point, that we need to decriminalize drugs. I was really appreciating Dr. Eddie Machtinger's points earlier about trauma being the root of, among other things, substance use disorder. And it sort of, that calls into question how we could possibly criminalize people for behaviors related to something that, first of all, is so deeply rooted in adverse childhood events and in trauma. And, what is that, putting someone in jail for having childhood trauma is only amplifying all of that trauma. There's nothing about that makes anybody any healthier. So there's that. And incarceration is associated with higher risks in terms of unsafe injecting drug use, unprotected sexual contact. Up to 25% of people with HIV are incarcerated every year in the US, many of them for drug offenses. We are continuing to re-traumatize a population. We are criminalizing a population that needs health. That's not even getting into the racist roots of the war on drugs and the way in which the war on drugs was created as a system of racial control and continues to operate that way. The ways in which mass incarceration and the war on drugs has an extraordinarily racially disproportionate impact, particularly on the African American community. That's a whole other presentation and talk, but it's one of the reasons why there are higher rates of HIV infection among African Americans in this country is because of the impact of incarceration. And so what's the alternative? Well, one of the alternatives is what they've done in Portugal, where they decriminalized personal use of drugs, of all drugs, whether marijuana, cocaine, heroin, MDMA. And they did it in part because they felt like, because social inclusion was a huge value, social, cultural value in Portugal, and they felt like people who use drugs were continually being excluded. So they came at it from how do we better include these folks? And what they came up with was decriminalizing drug use, and at the same time, vastly scaling up their treatment capacity, mostly for opiate dependence. And so what happens now if you come to the attention of law enforcement for your drug use, you go in front of a commission. It includes people with health expertise and credentials, social workers, legal folks, and they come up with, at most, a civil penalty, and they can also have you go into treatment. The results have been really dramatic. So HIV rates have dropped substantially in Portugal. Overdose deaths have dropped. Actual drug use has dropped. Crime has dropped, and needless to say, they've vastly increased the number of people in treatment. So they've been doing this for well over 10 years, and these findings have stuck. So when it comes to getting to zero, the way that we phrase it here in San Francisco is getting to zero means zero transmissions, zero deaths, and zero stigma. And I know you've already been talking a bunch about the different models for this. But how do we get to zero transmissions for people who use drugs? And that includes access to treatment, syringe access, supervised consumption services. How do we get to zero deaths? Again, substance use disorder treatment, naloxone, and decriminalization. And then how do we get to zero stigma for people who use drugs? And I think the primary way we're going to do that is by decriminalizing it. I think it's, the connection between being seen as a criminal and being seen as a stigmatized identity is so strong. And it's hard to know which one will need to come first, whether it's destigmatizing drug use or decriminalizing it, but we need to be working on both, because one won't happen without the other. So I think there are probably a handful of people in this room who know what this is. Does anyone know? Yes. And I'm looking at Judy Auerbach, who used to work with this. So what is this? Yes, this is the original buggy that was used here in San Francisco to distribute clean syringes as a volunteer underground civil disobedience activity that now has a home at the San Francisco AIDS Foundation. It has, and this is part of our roots as a movement. Some of the people who pushed this buggy around were researchers who were tired of just doing research and not able to actually put the research into effect. We need to be not just doing the research, but taking the research and turning it into policy and using the research and the love to save lives. So, the context around drug policy is everything that Jeff said it is about HIV and then some. Attorney General Sessions is doing his best to bring back, I don't even think it's the 50s, I think it's like the 1930s, the 1860s. He's trying to bring back profoundly racist policies, and he's trying to bring back the war on drugs. Fortunately, legalizing marijuana is more popular than Trump or Sessions and will outlive both of them, I believe. There was a poll out today. So this is my, the context of this is that we're in this incredibly repressive national government, national administration, but we are winning at the local level, we're winning at the state level, and we can still, take our baby buggies out there and hand out sterile syringes or whatever it is that people need. So that's my call to action. Find the baby buggy in your life and figure out how to put research and love into action. Thank you.
Probably have no more time than about 1 or 2 questions, and then we'll move on. So if you could come up to the mic to ask the question. Let's see, 1 and 2.
Tony for a minute. Come on, Tony. Come on. I'm just going to get up here real quick. Actually, thank you both for great presentations, and I want to ask you, Laura, if you could comment a little bit like what Jeff did around, quote, the opioid crisis and how we're really supposed to be feeling about it, because quite frankly, it's very painful for some of us to see this kind of celebrated conversation about the opportunity in this, what is a newfound crisis in our country, when, as you know, and your involvement in your work, it's been going on for a long time. We've been struggling. We've been left out of conversations. People are working on it. So what's the best spin? What's the best spin on this reality now so that we can feel good about embracing the work, going forward, supporting it, and working through that cognitive dissonance of it all?
Yeah, absolutely. And I think, those of us who have been working on this are profoundly aware of the ways in which, and trying to call out the ways in which the opioid crisis, this like new face of drugs, this sort of kinder, gentler war on drugs. Michelle Alexander did a keynote at our conference a couple of weeks ago, and she said, as the face of users and sellers got whiter and whiter, the drug war got nicer. And I think, every time I see one of these headlines about people dying, deaths of despair in Appalachia and so on, yes, that's true, and that's also what I would call the deaths of people dying of crack-related diseases in urban areas in the U.S. Those were equally rooted in despair, equally rooted in trauma. The only thing that's different now, obviously, is that it is being perceived as a white issue, and that allows all of the sort of white supremacy that this administration is sort of highlighting to come into play around it. And I think if we don't learn our lessons from the last few drug epidemics, every decade, every few years, there's a new crisis. The opioid crisis is really devastating in terms of the number of people that it's killed. But if we don't try to lock in any wins that we make, and if we don't try to be very explicit about the part of the reason the opioid overdose crisis is as bad as it is because of the racist way that we responded to the crack epidemic when we did. If we had responded to that differently, we wouldn't be in the place that we are now. I have lots more thoughts, and I can talk about that more, but I think making sure that we are figuring out how to save lives now, and making sure that we are able to talk about the role that racism and white supremacy has played in how we got here.
Thanks, Laura. Thanks, Jeff. I spend half my time in Appalachia and half my time in DC. So I have two very different perspectives on the drug epidemic and the drug world in the United States. But one of the challenges that now that we're dealing with what I call the Becky heroin epidemic, it's a very different response, right? So my question is, as we are also looking at the decriminalization and the legalization
of marijuana in various jurisdictions, and we're looking at this new face, quote unquote, of an opioid epidemic. Where is the pairing with figuring out strategies to get folks who have been arrested and who are now still locked up? Because, you know, we can move on with, let's figure out a solution to the opioid epidemic, let's get safe syringe sites, let's do all of this, but we still have tons and tons of folks that are locked up who are Black and brown for low levels of use. So my question to you, Laura, is how is it that we're going to create a parallel track to work on getting these folks released or getting records expunged? And Jeff, then my question to you becomes what I asked you a little bit about at lunch. What's our regional response look like? Because I don't know that it can be a national response because we don't have a national effort for legalization and decriminalization. It's a states' rights issue.
Thank you. That's an excellent question around marijuana. And it's one of the, so when we worked on Prop 64 here in California that legalized adult recreational use, we made sure that it was retroactive, that it includes both eliminating anyone who was incarcerated because of charges that were now legal was able to be released. People can get their records expunged and get that completely taken off of their record. There are a number of things in that, and I think that it's worth, if you live in a state that has not yet legalized marijuana, you know, we need to make sure that when we are legalizing marijuana, that we are doing it in a way that repairs the damages done by the war on drugs. So that means being retroactive in terms of the criminal penalties and expungement. It means making sure that the profits and the proceeds of marijuana sales are invested back into the communities that are harmed. Here in California, it meant that we take some of those revenues and use them to repair the ecological damage that's been done in our state forests and so on. It's not, we can't just legalize a drug and move forward in a white supremacist country. The only way to do it ethically is to make sure that we have a reparative justice frame around how we're legalizing marijuana. So that's what the Drug Policy Alliance has been committed to. There are definitely other people. I can also talk a lot about this, about how do we make sure that there's a pathway for people who've been selling on the illicit market into jobs in the legal market. Because if all we do is make new jobs available or ownership opportunities available for predominantly white people who already have access to capital and shut out the folks for whom this has been their primary way of making a living and their primary economic support, in part because other industries aren't open to them, will have done more harm than good if we don't figure out how to make those pathways happen. So again, that's a whole other topic that I can talk about at great length. So I will leave it there.
And I'll just try to be really brief. I don't think there's an easy answer, but I'd say two things. I actually did a Hill briefing earlier this week on some of these topics. And there, AMFAR has a new database on opioids and health indicators, and it shows that, you know, CDC's identified 220 counties at risk of a Scott County-like outbreak in Indiana. 93% of those counties don't have a single syringe services program. You know, so I think, and even in, you know, the counties that do, but think about even our urban areas. Do we have adequate capacity anywhere? So I think we need to focus on scaling up access to syringe services everywhere, but I agree, it's right, it won't look the same. But the other message, and this is something where I've changed from when I was in the administration, I used to say, and I probably said this to Laura, like, let's solidify the consensus on syringe services before we talk about safe consumption. But now I'm like, these issues will always be controversial, we can't wait. And if you are gonna tell me you can't just take an off-the-shelf thing that works in our cities and apply it to rural America, then we can't wait till we perfected it in San Francisco and Seattle to start the experimentation in rural America. I don't have the magic political solution to how we do it, but I think when crises become as severe as they are now, it creates opportunities. So I just think we need to keep pushing on some of these ideas.
Great. Well, I'd like to give a final thank you to our two speakers for this session. And we'll turn it over to Mike.
Okay, we're a little overtime, but we've reached the final talk for the day. I'm particularly happy to be able to introduce this because one of the original missions of the SBSRN was to develop and to promote and to share tools that could help corps across the country to be successful. So we're going to hear about the Social and Behavioral Instruments Database. It's a web-based system that Carol Golan will describe, and Brianna Castaway will demonstrate. So, Carol? By the way, Carol and Brianna are the core, they are the behavioral core for the UNC CFAR.
Have to move this down even more. Okay. Well, thanks a lot, Dave. And I want to thank the SBSRN and also our hosts here at CAPS for making this time for us to share with you a little bit about the SABI. It's something that is close to our hearts, which I'm not sure what that says about us, that we get so excited about social and behavioral instruments, but we're very excited to share this with you. You know, we started this morning with Judith's comments about, she made several key points, but one of them was about the importance of knowing what it is that we're measuring. And to be able to do that as social and behavioral scientists, we really need efficient access to valid social and behavioral instruments. And so that's what sort of the need for that is what started our developing this database in the first place. And as Dave said, the SBSRN, when it first started a while ago, it really was not just a way for us to put on really great conferences. And this is a really great conference, but we also really part of our goal is to work together, to share resources with each other, and to look for opportunities where we can collaborate with each other. And so we're hoping that this can become that and sort of provide some opportunities like that. So in that vein, we wanted to share this with you. So what is SABI? We call it SABI. It's actually something that we started back in 2005 when I first came on as the SBS core director. It seemed like we were getting a lot of requests for instruments and help with surveys, and it seemed like a sort of naively a good idea that we should just collect these so that we could then easily share them with people. And so it actually started out as a master's student practicum. Since we don't have a lot of money in our core budgets, I thought, oh, this would be great. I'll just have a master's student do this as their practicum. We'll collect all the instruments and we'll have this great resource. Well, so now 12 years later, essentially what's happened is it's gradually expanded and evolved over time. It's become more robust. And so at this point, we developed more standardized ways of identifying the measures and the domains. At one point, we then were able to get all the instruments. That was a whole project. We then contacted all the authors to get permission to share the instruments. So it's been a process. But the bottom line is we now have this web-based, user-friendly, searchable database of surveys and scales that measures social and behavioral constructs that are relevant to HIV research. And so it's really it's available on the web. You can go and you can see it now with some caveats that Brianna will tell you about. But it's potentially valuable tool for all of you, all of us, and so we just want to let you know about it. But we also have recognized, and Dave helped us with this, that it's something that is going to require additional resources moving forward to be able to make it sustainable, because it needs to be updated. We created it, and now we need to keep updating it. So once we recognized that, with encouragement from Dave as a member of our external advisory board for our CFAR, we enlisted help from the business school at UNC and a student, MPH student who is also an entrepreneurship student, and she did sort of a gap, what they call a gap analysis in the business world, and identified where this really, what it added to the market, essentially, who else was offering, and several people here, UCLA, UCSF, as well as UConn, offer some databases, but ours seemed to have some things that differentiated it that might make it worth trying to disseminate more broadly and let people know about. And she also, they identified several recommendations of things that we could do to improve it. And so based on that analysis, we now are at SABI 2.0, which Brianna's gonna just do a little demo in a minute. But I wanted, before we move to the demo, I just wanted to point out some of the unique features that are available. The other thing I should say is this also is a little plug for our poster. So because we just have a very brief time here, I would encourage you, for details about the methods and the domains and whatnot, to just visit us over at the poster session. But some of the unique features of SABI. So what makes this special? Why do we think this might be useful to all of you? First of all, we do systematic review of the measures. Some of them are actual systematic reviews, the last couple that we've done. But regardless of whether it's officially a systematic review, we carefully do extensive reviews and validation of instruments and vet them with content experts. We also have a sort of unique search component where the users can search the database for within each domain, and we have 12 domains. There are also 28 subdomains. You can look for the name of the instrument, the author, the year, et cetera, all of these things that are listed here, as we'll show you. The domains are all for HIV-specific instruments or instruments that have been widely used in HIV-infected or at-risk or affected populations. We also provide this standardized output, and I think this is what often is not available, where we have a PDF file for each instrument with the title, the source article, and the survey response options, as well as information about the validity and reliability. As I mentioned, we have gotten author approval, and we also provide citation assistance. So that makes it easy for you to just use the instrument. You don't have to contact them yourself. We've already done it. And we're also now collecting user analytics that can indicate where we can make iterative improvements, and you can also see which ones are most used. And then finally, we have standard vetting of the information on the website that shows you the exact methodology that we use to find these instruments. And basically, it's a 3-step process. We do environmental scans of key domains. We consult with key domain experts, and then we systematically abstract key instrument characteristics and psychometric properties, and then obtain the author approvals for sharing the instruments. This just shows you the 12 domains that we have, ranging, as you can see, from social support, gender-based violence, mental health, stigma, attitude, self-efficacy, et cetera. The ones we have most recently updated, social support and gender-based violence. And gender-based violence, we're just finishing up, and we're just starting an update of HIV knowledge. And these are the dates we have for updating the rest of them over time. They're all available, but they're not all updated yet. And this is what, I'm not going to go through this because Brianna's going to show you, but this is what it looks like if you do a search and you come up with domains, and then you can click on the actual instrument for the PDF. And then finally, before I turn it over to Brianna, I just want to acknowledge, like everyone has done here, that takes a village, but Many research assistants help with these systematic reviews. Often they're doing it as internships or practica, which is part of what enables us to do it with the meager CFAR core budget. Content experts are listed here that have helped, and I put maybe you, because as I said, these are opportunities for collaborating, and we may want to call on all of the CFARs to help with this in providing expertise and suggesting other domains that we might want to add to this. And then finally, the UNC Penn CFAR has actually contributed some money to this so that to help with making it sustainable. Duke CFAR shared some of their mental health instruments with us. And the SBSRN Executive Committee, and again, maybe your CFAR. So part of what we're thinking about, and we want you to help us with in terms of making this sustainable, is brainstorming how could we do this? Could we write it into the SBSRN renewal? And that's something the Executive Committee is considering doing. Could we ask all of your CFARs to contribute a little bit as a subscription so that you could then access these and we could hire somebody to update them on a regular basis? Or you all may have other ideas as well. And now I'm just going to turn it over to Brianna so she can give you a brief demonstration so you can see what the tool looks like or how it works.
Okay, thank you, Carol. So I'm going to go over 3 things on this website. I'm going to do it in less than 2 minutes. Okay, first thing, I want to kind of highlight, this is the home screen here. In your program, towards the back, there's information, and the website is sabby.unc.edu. If you go to the About Sabby, you can see here when we're actually going to be updating domains, and then also you can see the methodology that we use. And we also have put boilerplate language for proposals. You can just copy and paste that right into your grant proposals and how to cite Sabby. Now I'm going to show you how to search Sabby by domain, and then I'm going to show you how to search Sabby by population. So if you go here, View by Domain, all of our domains and subdomains will pop up. I'm going to go ahead and click on Adherence. And you see here we've listed all the adherence measures that we have currently in Sabby. As Carol mentioned, you can see here this domain is scheduled to be updated in spring 2019. That actually may be sooner. We're actually going to do this review over the summer. It does take a bit, though, and also because we want to get author permission, that also adds to the timeline. But if you look here, everything that's blue means that you can click on it. And so if you click on the citation, it will actually take you to Google Scholar, to the original source article, and you can look also where it says, view or cited by. If you click here under View Details, every instrument has information about the actual instrument. And so everything from response options, scoring, survey items, reliability, validity, and also terms of use. And so to get permission from authors, we wanted to make sure that we showed them that your work is going to be cited. And so we have down here how to actually cite the instrument. And so to make it a little bit easier too, we have it where you can download this page in a PDF. And for some instruments that actually are pretty, we actually have the actual instrument embedded into this PDF, so you can actually copy and paste that. Now I'm going to show you the last thing is by searching by population. So if we go to search the database, as Carol mentioned, there's many ways that you can search this database, by domain, by language, by author, by name. You can also do it by population. So I'm going to go ahead and click women, and I'm going to click search. And these are all instruments that have been used within female populations. And so here you can click on View Details and go and see the information for this specific instrument. But you can also say I'm really interested in attitudes to condom use. You can click there on that subdomain, and it will populate the table to have all of the instruments that are related to attitudes on condom use. Same thing with attitudes, where you can click on the domain and it will populate all the ones for attitudes. And if you're in a hurry and you just want to, I love this, I want to read it on the bus, print result. You print the whole thing. So I do have a few caveats. This just went live last week. I'm new to web programming, but there are these things called bugs, and they are happening. My brother got all of the computer skills in my family. So we're working on those bugs, and so give us a couple weeks. If you see that something is not, if a link isn't there or a PDF isn't there, we're aware, we're working on it. And also, please see our poster, and we look forward to working with you on making this a great resource for everyone. Thank you.
Okay, now didn't I tell you? Wasn't this a great day? What wonderful speakers and presentations we had today. Couple housekeeping notes. One, the shuttle was leaving at 6 o'clock this evening to take folks back to the hotel for folks who need that shuttle. Second, please join us for our poster reception, which is happening in the back, and there's the reception area outdoor right outside this door where you had your lunch. And please come back tomorrow. As you can see, we have a very lively agenda for tomorrow as well. We'll be hearing about the social behavioral aspects in the CURE research agenda, as well as two very distinguished, invigorating, I'm sure, plenary discussions, one from Susan Newcomer and the other from Tom Coates, who are both just been in the struggle for a long time, and I know we'll have some very interesting, compelling, and inspirational things to tell us tomorrow. So thank you for your attention today, and please join us at the reception.